Hi, I'm Dr. Bob DuVall, the Residency and Fellowship Program Director at Sports Medicine of Atlanta, and here I am at Oakworks using the PT300 table, the electric high-low. And we've been doing a series of part one showing the benefits of doing manipulation on this table, its ergonomic design and features and convenience, as well as patient comfort. And we've also gone into the neuromuscular re-education part, where we looked at resetting the spindle after doing a manipulation activity. The third part, this segment, is going to look at the ADL, the activities of daily living, and the therapeutic activity that we need to do after we do manipulation and neuromuscular re-education. We need to take and apply the manipulation, the neuromuscular re-education, resetting the spindle about the manipulated part, body part, and putting it into some functional activity. This is particularly relevant at this time of healthcare reform because we're moving from procedural-based payment to outcome-based payment, pay for performance. And to acquire that pay for performance, we need equipment that will enable us to conveniently, without going to some major investment of equipment for functional outcomes, but right in the treatment environment, to manipulate the patient, to do neuromuscular re-education, exercise to the patient, to put it into a functional activity right in the same convenient environment. To illustrate this, I want to show you a few features of this table. This is the only table that I know of that provides us the opportunity to go down as low as 16 inches in depth. This enables us to do deep squatting activities, very similar to what we need to do in activities of daily living. It enables us to put the patient into positions that we can work with the patient with a form of rhythmic stabilization and perturbation activities. But please notice the low dimension this table affords us to conveniently go into right in the treatment environment. Okay, so I'd like to illustrate the features of this high-low feature that we can use for ADL and therapeutic activity, the most essential part of our rehab. Reminding ourselves that we get reimbursed for outcome. It's going to be critical that we're able to put the patient into positions that we can improve their Berg balance or their functional reach tool just immediately in a convenient environment. So let me illustrate our point. Brendan, would you come and join me, please? I'm going to ask you, Brendan, if you would, to get on one knee, part knee standing here, and I'm going to adjust, face this way, please. Stand a little bit there, good. And I'm going to adjust this so he's not in side bending. And that's perfect right there. So having him in proper position here, we can take the transverse abdominis and the multifidus muscle that we worked on the mat table on as a neuromuscular re-ed and put it into functional position. Brennan, put your hands like this. And now don't let me move you. Hold that. And I'm going to palpate, reset and draw in the muscle here. Now hold that. Don't let me move you. Be a statue and fight me. Rhythmic stabilization to transfer the learning from the mat to now a functional activity with unilateral weight bearing, unilateral standing. And don't fall forward, fight, and hold. Excellent. Now let me ask you to have a seat on the edge of the table, please. If Brendan had spondylosis, he had hypomobility in his lumbar spine, I would be interested in increasing his flexion, his pelvic flexion motion. So to do that, I would lower the table to its lowest position. It's here that he's more likely to be able to find a lower seated position, the actual neutral spine of his lumbar. So to do that, I'm going to ask you to arch your back. Now pull your belly button in and go too far back. Not neutral yet. There you go. Now back to neutral. Hold that right there. Hands right here for me. Again, fight me. Don't let me move you. Hold that. This, needless to say, goes lower than what we can use with a Swiss ball, and we're on a more stable surface. So this would be a nice progression before moving the patient to the Swiss ball on a more unstable surface. Likewise, if he had difficulty with sit to stand, with this table, I can very conveniently bring him to a partial standing position. Elevating the table to this height, will make his standing ability much easier. And then the progression would be from a lower stance position. But let me ask you again, arch your back in, tilt pelvic tilt the other way, find neutral. Now take my hands and come up to a standing position, please. Now back down and back up and back down and back up. Needless to say, for a geriatric population, this would be a very nice progression toward independent, safe balance and gait. Now have a seat again, please. As mentioned, the progression would be from a very low position. And again, this table goes so low that I can do below parallel squats, sit to stand activities, which is going to be great for the glute max, glute med, and his quadricep strengthening. Needless to say, it's also a great treatment for spondylosis. Take my hands, come on up to stand, please, and back down slow. Hold neutral position as you do it. You arched a little bit too much that time. Reset. Okay, now hold that right there. Keep that as you come to stand. Perfect. Excellent. Keep it as you go back down eccentrically. Fight it, fight it. Nice. Up again and back down. So with this feature of high-low, we can progress from the neuromuscular re-education exercise to apply them to function. So we can be guaranteed to get a measurable functional outcome. That Berg balance functional reach test is going to show measurable improvement objectively because of the manipulation we did, the neuromuscular re-education we did, followed by sequencing all on one table conveniently in a small space.